So my name's Jonathan Thackeray. It's Jonathan. Last name's T as in Tom, Hackeray. And I am the principal investigator for the Train Collaborative.
Thank you. Good. Lean in and look like you're in pain
when
you say it. Just saying. Oh, I don't have questions for you.
No,
I thought I did.
no, we don't.
Okay.
But I figure you know the kind of things to ask.
Okay. Do you want me to get Ange?
No?
It's so funny because it's freezing in the other room. And
That's why I just noticed
I'm
it's
like
a little
warm
warm
in
in
here.
It's warm in here.
It's the lights.
Kind of felt the same thing, but yeah. I might get a couple little tissues too, just to have.
Powder.
Powder.
I glisten.
Not right now. Just in that Arizona heat. You're sparkly.
He gets back.
So you want to cover, just so I'm clear, you want to cover, or we are covering with you, the overall perspectives from the collaborative, Sentinel Injuries 101, importance of the work.
Yeah, maybe how we got started. Am I looking at you when I'm answering? I'm not looking into the camera, am I?
Ignore the camera. That's what I'm guessing, right?
Sure.
Ignore the camera, just concentrate on the interviewer.
Okay.
Yeah, I mean, I'm ready. whenever,
Okay.
So.
Okay.
Did you make that?
You good?
Yeah.
All right. So Jonathan, tell me a bit about how the Train Collaborative started.
The Train Collaborative really was born out of informal discussions that those of us who do child abuse pediatrics around the state were having. We were noticing this common theme that children we were being asked to evaluate in the hospital for abusive injuries, when we went back through their medical records or we talked to their caregivers, turns out it wasn't the first time they had come through our hospital's doors with an injury. But what we were noticing was that the first injuries were often minor injuries. They were seen in our urgent care with a small bruise on the cheek, or they were seen at their pediatrician's office with a small tear on the inside of the mouth. And by the time we were seeing them, they were experiencing significant and severe abuse. But we were noticing this theme that kids were experiencing recurrent injury, and it seemed to escalate over time. And at the same time, we were having these informal discussions. A colleague of ours, Dr. Lynn Sheets from Children's Hospital of Wisconsin, was describing, publishing her experience of a group of infants that she was evaluating for abuse at her hospital. And she found that of children she was evaluating and felt to be definitely abused, when she went back through their records and talked to their caregivers, almost 1 in 3 of those children had experienced some minor injury, what we call a sentinel injury, in the past. What she observed was that infants who had had a sentinel injury, in over half of the cases, the medical provider was aware of that injury, and yet these children were going on to experience recurrent and much more significant abuse. So we, how do I want to say this? Go ahead.
So then, with your colleagues here in Ohio, what became the purpose of the Train Collaborative?
So the purpose of the Train Collaborative was to improve the pediatric provider's ability to recognize and respond to these sentinel injuries. Like I said, we were seeing children who were experiencing re-injury, and oftentimes that injury seemed to escalate subsequently, and we felt it was unacceptable. We felt there was an opportunity to improve care for young children.
What did the data show you about how many sentinel injuries there are in Ohio?
So when we looked at our baseline data for the collaborative, we found that the number of sentinel injuries was surprisingly low, especially compared to some other data that's been published. We found that about 6% of infants who experienced a sentinel injury came back to the hospital within 12 months with a subsequent injury. And we believe that number was artificially low. We feel that the low number represents either our inability to recognize these injuries or our failure to document these injuries when we see them.
What else did the data show? Who are these injuries happening? Which kinds of children are these injuries happening to?
Young babies.
All right, so let's talk about that. Let's define who we're looking at in the data with the Train Collaborative.
So the collaborative is focused on sentinel injuries that occur in infants younger than 6 months of age. We know from other research that the younger the child, the higher the risk they are of experiencing abuse, and the higher the likelihood of morbidity and mortality from that abuse. So we chose to focus on the youngest infants, those less than 6 months of age. We did that in part because young infants, they're developmentally not capable of harming themselves, right? They can't walk around and fall and bonk their head. They can't take a spoon and shove it in the inside of their mouth and injure their mouth. So we really wanted to focus on those infants where injuries are so rare that when we see them, we have to ask ourselves, why is that injury there?
Is that we were recognizing sentinel injuries in?
Sure, and I'll say two things about that. First, we noticed that there was incredible variation across the 6 children's hospitals in our ability to identify infants with injury. So one hospital in our baseline data had identified 50 infants with sentinel injury in a year. A comparable hospital in the same time frame had identified five times as many infants with injury. And so to us, that variation was significant and required more exploration to figure out why it was there. What we noticed in our baseline data was that we had predominantly white infants covered by Medicaid for insurance. And the demographics of the infants in our baseline cohort don't line up with the demographics of children who present to the emergency department. And so for us, it was another area of concern that we had this predominantly white cohort of young infants when we would have expected there to be more diversity in that population.
Throughout Train, you've done lots of education, it sounds like. Can you talk a little bit about what the data told you next steps should be and what kind of education then the collaborative was hoping to get spread among providers?
Sure. So, again, one of the first things we observed within the 6 children's hospitals was there was tremendous variation in our ability to identify infants with sentinel injury. We surveyed several hundred providers across the state, and we learned pretty quickly that there were pretty good educational gaps with pediatricians, nurse practitioners, social workers about what sentinel injuries were, why they were important, why they should be concerning to the healthcare provider. And so one of the first activities of the collaborative was to basically disseminate standardized education across the 6 children's hospitals to help fill those educational gaps.
Follow-up.
Yeah. So with any variation in care, there's the risk of harm and poor quality care. So as a collaborative, we wanted to identify ways to reduce variation both within our 6 children's hospitals as well as community hospitals that we partner with as part of the collaborative. So we developed what we're calling a bundle of care, and that's essentially a checklist of a few items that we would encourage participating hospitals to do for all infants. The first element of the bundle is very simple. It's undressing an infant from head to toe. I say it's very simple. The first element of the bundle is undressing an infant from head to toe every time they come into the emergency department. It sounds like an easy thing to do, but we found, to our surprise, that several children's hospitals were not doing that. It's been an area of pushback from providers because it's not part of their usual practice. But our sort of our mantra in the collaborative is if you don't look for injury, you won't find injury. And so we're encouraging our collaborators to undress infants as the first step of that bundle. The rest of the elements of the bundle apply to those infants when an injury is identified. First, we want providers to do a skeletal survey for infants with injury. Skeletal surveys are a set of x-rays. They are evidence-based, widely recommended by leading pediatric groups as a standard of care when you have infants with injury. We found that, again, across our 6 children's hospitals, we were doing those skeletal surveys less than 40% of the time when we were seeing infants with injury, and so that was a clear gap in quality of care that we wanted to address. The third element of the bundle is to conduct a psychosocial assessment of the caregivers. Again, children rarely experience abuse as an isolated one-time event in the home. The reality is that children are recurrently exposed to harm, and there are several risk factors associated with that harm, whether it's substance use in the home, mental health issues with the caregivers, previous law enforcement involvement, previous children's services involvement. And so we're giving our collaborators a standard checklist of psychosocial elements that are important to consider for families. The final element of the bundle is we're asking our collaborators to pick up the phone and reach out to a pediatrician with expertise in child abuse in their area. We have several of them across the state. All of them there's access to expert opinion 24/7 for providers. And we'd like them to reach out and share with us the details of the infant that they are seeing, what they've identified from the skeletal survey, what they've identified on psychosocial assessment. And the goal is that we can then help that provider navigate that family's care, whether it's recommending additional workup to exclude medical causes or identify additional injury, or it could be helping a family more efficiently navigate the healthcare system. We don't want families bringing infants 3 hours to a regional children's hospital, having to wait a long time in the emergency department, only to be looked at by a pediatric provider and being told there's nothing else that needs to be done, you can go home. So as much as we're trying to identify injury, we're also trying to improve the experience for families who may be undertaking unnecessary time and expenditure.
Fantastic. Excuse me. It's my understanding that the TRAIN Collaborative had 3 phases. Can you briefly describe an overview of each of those phases?
Yes. So the collaborative is operating in 3 phases. Our first phase was focused on the 6 member organizations of the Ohio Children's Hospital Association. The second phase, we took each of those 6 children's hospitals and we partnered them with a couple regional community hospitals in their area. And we did this because we learned from our baseline data that more than half of infants with sentinel injuries don't come through the doors of our 6 children's hospitals. They present at community hospitals in their region. And so we thought that was a necessary step and an important step to try and improve the quality of care that these infants are receiving. I hear one of those infants now.
Baby Rachel, I bet.
The third phase of the...
My hands on her, by the way.
What's that?
Can't wait to get my hands on her, by the way.
Hey, Haley. The third phase of the collaborative we are doing in conjunction with the Ohio chapter of the American Academy of Pediatrics, and we are working with approximately 10 pediatric primary care practices throughout the state. And we think this is an especially important phase because these providers are interacting with infants every day, and we think having them as part of the collaborative will give them an opportunity to both learn from each other and teach each other about their experiences in identifying infants with injury and how to navigate these situations with the families that they see.
One last question, unless you think I haven't covered it. What is it that you see for the future of TRAIN? In particular, it's great to have this kind of education and quality improvement initiative within a healthcare setting or
Mhm.
system or partnering systems. but is there opportunity for child welfare, law enforcement, others that are in the child protective services arena to also partner and learn more about sentinel injuries and reducing their reoccurrence?
I think one of the key lessons that we've learned from these first few years of work is that as medical providers, we are just a small piece of the larger system that these children interact with every day. And so we've had lots of opportunities to speak to child welfare professionals, law enforcement professionals around the state, and we're finding that the same educational gaps that we have as pediatricians, they're shared by our colleagues in child welfare and law enforcement. Many of them don't understand what sentinel injuries are, why they're important, why they indicate that a child might be at increased risk in the home. And so I think when we think about the future of TRAIN, I think figuring out how to better collaborate with these other systems of care that interact with these children and help care for these children is going to be critical. I think there's tremendous opportunity there.
My name is Kristen Crichton. First name is Kristin, last name Crichton. I'm a child abuse pediatrician at Nationwide Children's Hospital.
Good. And just ignore me in the camera, just concentrate.
Okay. So bias has been identified as the source of disparities in other aspects of healthcare. Prior to this collaborative, has bias been documented as an issue in the evaluation or reporting of child abuse?
Past research has found that discrepancies in both race and socioeconomic status in the evaluation of children for non-accidental trauma.
Yeah, just ignore me.
I'm sorry.
You're fine.
Should we start over?
I'll just read the last part.
All right.
So prior to this collaborative, has bias been documented as an issue in the evaluation or reporting of child abuse?
Past research has found discrepancies in both race and socioeconomic status in the children that are evaluated for non-accidental trauma. One study found that white children were more likely to be misdiagnosed when they presented with abusive head trauma, and other studies have shown that children of minority race were more likely to be evaluated for non-accidental trauma.
You studied infants with bruising who received the evidence-based recommended workup of a series of x-rays known as a skeletal survey. Was bias an issue identified in this study?
Can I hold on for a second? Sorry, let me think about how I'm going to word that since they're not going to hear your question. All right. All right. In our study of over 300 children who presented to one of the 6 children's hospitals in Ohio, sorry. Okay. All right.
The thing about this is you look beautiful on camera. We ask all of these questions to really get like 30 seconds.
Okay, all right. In our study, including over 300 children evaluated at 6 children's hospitals in Ohio, okay. In our study, including over 300 children under 6 months of age who presented to one of the 6 children's hospitals in Ohio with bruising, we found that children of lower socioeconomic status, as measured by their public insurance status, were more likely to be evaluated for non-accidental trauma than children of higher socioeconomic status.
So in other words, poorer babies get skeletal surveys more.
Yeah, so in other words, we did see bias in who was being evaluated for non-accidental trauma. Specifically, poorer children were more likely to have a skeletal survey and have non-accidental trauma considered as a diagnosis than wealthier babies. Sorry, I can say that not in a questioning way. In other words, poorer children who presented with concern for non-accidental trauma were more likely to be evaluated for these injuries by a skeletal survey or a series of x-rays than wealthier children were.
Why do you think that bias exists among providers? And/or what's the best way to help providers overcome the biases that you saw in the TRAIN Collaborative and this related study?
I think the first step to helping improve recognition of sentinel injuries or injuries that are concerning for non-accidental trauma in these young infants is education of the providers who are encountering these young infants. Educating them as to how child abuse presents in young infants and to what the appropriate approach should be in the evaluation of these young infants for additional injuries. I think it's also important for all medical providers to recognize that we all have an unconscious bias that may contribute to how we make medical decisions. And with awareness of this bias, we can hopefully be more objective and uniformly evaluate all children in the same way, especially with concern for non-accidental trauma.
Has there been any other studies regarding provider bias in child abuse pediatrics?
Yes, provider bias has been seen with regard to both race and socioeconomic status in terms of which children are evaluated for non-accidental trauma, with minority children being more likely to be evaluated for non-accidental trauma, as well as an overrepresentation of minority children in which children are reported to children's services for suspicion for physical abuse. Additionally, children of low socioeconomic status or poorer children are more likely to be evaluated for non-accidental trauma than wealthier children.
Has participation in TRAIN led to improvements for your hospital?
Participation in TRAIN has increased awareness of providers regarding the importance of recognizing these small injuries in young infants as concerning for non-accidental trauma, and in the uniformity of the approach to evaluating these children, such that all children that present with such injuries have the same screening for additional injuries done.
And this is just a question I have that may or may not make the video. If bias is present and it tends to, I don't know if favors the right word, but if we are seeing more minority and low socioeconomic status kids that get the full workup, why was the TRAIN cohort mostly white male? I mean, in terms of the baseline data that we saw for sentinel injuries.
So I don't think that we saw a racial difference in our study, and I think that the TRAIN cohort skews white because of the racial demographics that we're studying specific to Ohio. I think in Ohio, our demographic skews more white than in the national average.
Because that, I mean, like I said, that might not make the video, but I am really, really curious about that.
I don't know about male, but with white,
When we went to Casey, we got a question about that, just so you know. I mean, it was, we're presenting this data, right? And Jonathan has this slide that the majority of the babies that we saw that presented with sentinel injuries were white, they were male, and they were Medicaid.
so
And so I'm
it's
like, yeah, but then there's this great research that you've done in terms of bias from providers and how, you know, minority children are overreported to CPS. And so I was just trying in my non-academic brain to figure out.
So this, with this project, as well as with a project I did as a fellow, we don't see the same racial bias here that is seen with bigger studies involving different demographics. And I think it's because our demographic, especially at Nationwide Children's Hospital, our catchment area, does skew towards white more than the national
I
average.
just wondered if it was, and this is like dumb girl, right, not a doctor. I was like, I actually asked Jonathan out of just sheer ignorance, is it harder to identify a bruise on a black baby?
I do think, yes, I think that contributes to it. I also think that we see fewer black babies, so
Yeah.
it may be that we're less good at identifying it than practitioners who see more.
Sandra Spencer, Sandra Spencer, and I am one of the emergency medicine physicians here at Nationwide Children's Hospital.
Perfect. So, as an ED provider, do you see variations in how providers evaluate infants?
As an ED provider, we do see a fair bit of variation in terms of how providers evaluate infants. It's both inter-institutional and intra-institutional, so we see it kind of across the board.
Why do you think that is?
I think much of the reasons for these variations is based on both education and awareness of the issues surrounding child abuse.
So you do see a variation in how providers approach infants with sentinel injuries.
We do see variation in how providers approach infants with sentinel injuries. We see specific variation even throughout all different types of facilities, so even in academic, highly regarded institutions such as the ones that are part of our study.
Can you give me an example?
Sure. Some of the things that we are seeing is just recognition of SI, what the definition of of a sentinel injury may be. We also see some variation in how people handle those patients when they see them come in. So certain people will refer automatically to a higher children's hospital. Other people will try to manage it locally. So there's a lot of variation in how they would take care of these children.
You led the effort to survey providers across the state on their understanding of sentinel injuries. What did you learn from the survey?
So I think what we learned from the survey, from the TRAIN survey, is that there is a lot of variation amongst the ways that providers take care of these patients. Some of the biggest difficulties we saw were with recognition and awareness of the sentinel injuries. And one of the things that we noticed were specific barriers and challenges that providers saw. Some of the barriers and providers were specifically, again, just not being aware of what a sentinel injury was, and also what to do with it once it was done, once you saw it.
Can we do that one again?
Sorry.
It's okay.
My notes are not coordinating with what
No,
you
that's
said. I
okay.
apologize.
Sometimes it's nice to have a couple takes. No worries.
Which one? Where
I
are we?
like you, I'm on you led the efforts to
Oh,
survey.
yeah, okay.
So I like
Yeah.
how you combined that with the next.
Okay,
memo.
I
So,
can, yeah.
But do me this time, if you can, give me an example of like what is a barrier or a challenge?
Yeah, I
So
have-
we know it's not lawsuits, we know
Yep,
it's not.
I have it. I got
Okay.
it. I lost myself in my red writing.
You led the efforts to survey providers across the state on their understanding of sentinel injuries. What did you learn from that survey?
One of the things that we learned from our survey throughout this TRAIN experience was that there is a lot of difficulties with recognition and then further assessment of these patients when they come into the hospital. These changes and differences are even noted amongst some of our highest quality pediatric facilities, such as the ones that are part of this project. We also found a few barriers and challenges from the provider perspective. Specifically, interestingly, they were two kind of dichotomies. The first was missing child abuse, so not recognizing it when they were supposed to. And on the flip side of that was also being concerned about missing it when they saw it and not being able to recognize it. So we felt like that was a very interesting kind of juxtaposition of concerns.
So to state it another way, on one hand, you saw people not paying enough attention to it, and on the other, you saw people overdoing their assessment, if you will.
I think if you were to compare the two, there would be the people who felt like they weren't getting enough education, so they didn't know what to look for with a sentinel injury. And on the other hand, there were people who were concerned about calling something a sentinel injury that maybe was not. So there was concern about missing an potentially abusive injury, or potentially overcalling a normal injury.
What was most surprising to you about the survey? Is this in here? Were there areas that you expected providers to recognize as challenges or barriers that you and your trained colleagues didn't end up seeing?
Yeah, I think we had a couple specific questions that we were surprised were less concerning to providers than we had anticipated. One of the things that we thought would be a high concern was concern about being asked to join in court proceedings, and that ended up actually not being a very big concern for most providers. Another thing that was concerned is a concern that was expressed was concern about radiation exposure, and again, this was something that ended up not being a big factor in terms of doing workups on these patients. Both of those have been mentioned in previous studies of being an area of concern, so we were certainly surprised about that. On the other hand, there's also very, very clear definitions of what an abusive injury is, with a lot of research and manuscript publications behind it to support what those injuries are. And in addition, the National AAP has very specific guidelines about what to do when these injuries are seen. So we were surprised also that there was so much variation when there's been such clear support for defining these injuries and also such clear instructions on what to do when you find these injuries.
So going back to the dichotomy that you talked about, what kind of education for providers do you think is needed to overcome either the missing of an injury or the opposite
Yeah,
that you discussed.
I think there's two things that we really want to point out in terms of ways to educate other providers in terms of how to overcome some of these concerns. I think the first one is to recognize that there's always resources available to you wherever you are to get some advice about this. Most hospitals, most pediatric practices are associated with a large tertiary care facility, and most of those places either have an emergency physician or a child abuse specialist or physician on staff that can help answer questions for you and guide you through any concerns that you have. Usually when you have those types of resources, they also come with a social worker who can help guide you through the reporting process if ultimately that's what you need. So I think one of the things that we would like to make sure everybody's aware of is there's always resources and support for you as you're making these decisions. The second thing that I found interesting that I think we should probably focus on is making sure that we are aware of our own personal biases when we're assessing these patients. Education regarding your own biases may allow providers to be more objective when you're doing these abuse evaluations.
And then finally, has participation in training led to improvements for your hospital and your colleagues?
I think one of the things that we've learned here is that we actually are identifying more potential sentinel injuries. They don't all lead to a secondary finding of abuse, but I think we're doing a much better job of identifying these sentinel injuries. Also locally, we are having a comprehensive evaluation of how we care for these patients here at Nationwide Children's, and we're trying to come up with some methods in order to decrease variation in how we're taking care of them as well.
You know, when I started my career, I was an assistant county prosecuting attorney, and I think what shocked me most about that job was the way some adults treat children. Examples of child abuse and what I saw was just shocking. And, you know, I'm still shocked by it. I don't think it's something we ever get used to. So very important that doctors, caregivers, others recognize the signs of child abuse. And so what this study was about is trying to look at all the different signs of child abuse that would be out there, some that look very minor, but might be an indicator that there is, in fact, child abuse going on. And so this was a program that we funded from the Attorney General's office. It was not tax dollars. It was money that came in a settlement, $1 million. And we made that available to the children's hospitals in the state of Ohio and had them, they came up with this proposal. We thought it was a great proposal, and they are doing some amazing work in regard to this.
What are you proud of as far as this goes? I mean, it's not just Ohio sharing the information, but there could be an impact nationally too, Ohio being a leader in this area with this information.
The research that's being done will be able to be used across the country. This is research that has really not been done in this form before. They've come up with some good results, good in the sense of finding things that were indicators and doing a better job of being able to identify child abuse. What I experienced when I was a county prosecuting attorney was that many times when you saw a horrible case of child abuse, maybe a death of a child, you know, hurt very, very badly, and you really dug into it, you found that there were signs, there were indicators before, and yet those signs were missed. So the whole purpose of this study is to make it easier for people, pediatricians, for example, to identify very early warning signs of child abuse.
And this is sort of an obvious question, but why did you choose Ohio's children's hospitals to partner on this, and what do you think of them?
Well, we're very blessed in Ohio. I think that we sometimes take for granted all our great children's hospitals, but from one end of the state to the other, we have some amazing children's hospitals. I've had experience, my wife and I, with the use of children's hospitals with our own children. We've seen later on our grandchildren go to children's hospitals, and there's just something very reassuring when you walk into a children's hospital, you know that they're focused on children. They're focused on someone who, is the age of your child, and they know exactly what they are doing. So it was a very logical thing for me once we had this money to make the money available to children's hospitals and to really ask them what would be a good way for you to spend this money that would be able to accomplish something that you would not have been able to do without this $1 million. And this is the program they came up with. This is the study. And I think, what we're seeing is very, very positive results based on this study.
And I'm sure you're hopeful the impact will be, much farther reaching.
I truly believe that the impact is going to be not just on the kids in Ohio, but frankly, kids across the country. The data that they're coming up with certainly can be used and can be helpful to pediatricians from one end of the country to the other.
Perfect. Anything else you want to say?
Nope.
Awesome.
Paul McPherson, PaulMcPherson. I'm the medical director of the Child Abuse Clinic at Akron Children's Hospital in Akron, Ohio. Very good. You're going to ignore me and the camera, just concentrate on Okay. her.
And then the other thing to note is, so we'll edit out for any, if you want to start over, just feel free to stop. What they won't have, though, are my questions. So when you're stating the answer, feel free to state the question as a sentence when you answer.
Sure, okay.
So what did you learn about your hospital's approach to sentinel injuries through participation in the collaborative?
When we began to participate in the TRAIN collaborative, when we began to participate in the TRAIN collaborative, we discovered that our doctors, our emergency room physicians, our pediatricians were good at identifying big injuries that clearly show that abuse has occurred. What we also discovered is that there was room for improvement to learn about minor injuries, because minor injuries, although they look small, they can be a marker for ongoing violence in a home, either towards that child or towards other children in the home or towards other adults in the home. And those small markers of injury, those small markers of violence, may represent bigger issues that put children's lives and health at risk.
Can you describe an instance of success you've had with community partners as a result of the TRAIN collaborative?
Well, we've had some great success with community partners. Our adult hospitals that don't see children nearly as much have embraced learning about child abuse identification and child abuse prevention. One story in particular really stands out. A 2-month-old little boy shows up to one of the adult hospitals in the area. Mom had put this child down for a nap in the bed with 2- and 4-year-old cousins. A couple hours later, the mom goes to check on the child and feed the baby, and it turns out the infant was not using his arm. So Mom got concerned. Mom brings the child to that adult hospital, and she says, yeah, my 2- and 4-year-old were in bed sleeping with the infant, and I think they may have rolled over on her or something. So they get the x-ray and they identify a significant fracture in the child's arm. They go and talk to Mom about it. And they say, these 2-year-olds, they wouldn't be able to cause this fracture. Mom starts to tear up. She sobs. And then she says, well, actually, I was in bed with the baby. I'm the one that rolled over. I am so sorry. I didn't mean for this to happen. I'd never, ever hurt my child. So you have a mom who clearly cares for her son. You have a mom that appears very sorry for what has happened. And that may have been the end of the story. Through the TRAIN collaborative, though, the doctors and nurses at that outside hospital really thought through and said, well, we need to get some other x-rays just to make sure everything else is okay. Unfortunately, those other x-rays identified a significant skull fracture. Those x-rays identified over a dozen rib fractures. They went back to mom and they said, no, this would not have been caused by you accidentally rolling over. The child was transferred to our children's hospital. The child got additional care, and the violence that ultimately was identified in the home was addressed, and that child now is doing much better. Now, I find that story to be a success. Yes, I wish that child hadn't been abused. Yes, I wish that child didn't have fractures of their arm or ribs. But those types of injuries heal. What we didn't find, and what we would have likely found 2 weeks later, a month later, if that child was sent home, that child coming back with brain bleeding, that child coming back with swelling on the brain, permanent neurological injury, that child may have come back with permanent eye injury, or that child may have returned dead. This was a success because those hospitals are now looking a little deeper when there is a seemingly minor or, quote, explainable, unquote, injury that they wouldn't have thought twice about otherwise.
What would you say to other community providers that might not see the relevance of a single bruise in a young infant?
Well, I'll tell them that if they see a single bruise in a toddler who's walking on their shins or on their forearms or even one on the forehead, that's normal toddler. They can walk, they can fall, they can waddle like penguins and they topple over. Those types of small bruises are not a big deal in toddlers. But if you think about an infant, how many infants flip their arm or bang their arm on a couch side or on their crib? Do they get bruises? No. Otherwise, our hospitals will be filled with infants with bruises. Do they get bruises from their pacifier or if their car seat is too tight? They don't. Otherwise, we would be filled, our ERs would be filled with infants with bruises. What I would tell to those providers is that bruise in a 2, 3, 4-month-old infant is trying to tell us that you need to look a little harder to make sure that I'm safe, because these bruises just don't happen spontaneously.
Nick Lashutka, Lashutka,
And your title?
President and CEO, Ohio Children's Hospital Association.
Good. Ignore me in the camera, just cut you and Angela.
Oh my guys. Okay, so the first question is, why do you feel the Attorney General chose the Ohio Children's Hospital Association?
We've got a proven track record of collaboration with our 6 member hospitals, all of whom compete vigorously for market share, but all of whom set that aside when it comes to ways in which we can work together to better improve child outcomes. And we've got a strong track record of evidence that's been successful there. We're the only state, for example, that's received state dollars to do combined collaborative research. And that research collaborative, which was really formed here at Nationwide Children's, strongly supported with active participation from all 6 of our members, Akron Children's, Rainbow Babies in Cleveland, Toledo Children's, Dayton, and Cincinnati, has proven some very powerful results in other areas. So neonatal abstinence syndrome, babies that are born drug dependent, there was protocols for treatment that were had a lot of variance and variability. We got the subject matter experts together and were able to determine a better way to get those children treated and out of the intensive care units. That was better for the kid, better for the family. They could get back to work quicker. In a lot of cases, those are Medicaid kids, so it actually saves the state of Ohio tens of millions of dollars. And we felt it wasn't just enough to keep that internal to the OCHA hospitals. We partnered with the Ohio Hospital Association to spread it to all their birthing hospitals, further accelerating the improvement, further manifesting the dollar savings. And we always love to have private sector validation, so we were thrilled Cardinal Health agreed to financially support the exporting of that work to 5 other states. So Ohio being really the pediatric center of innovation, as evidenced by the NAS work. We've got pneumonia and asthma collaboratives as a part of our research work. Maturing, we're excited that we're going to have some really fundamental life-changing protocols coming out of that. The child abuse was a natural fit for the AG to give him and his team confidence that what they would be investing in was going to yield results. And of course, all that's built upon the foundation of our safety work, which was born here in Ohio, our 6 hospitals, plus the Cleveland Clinic, plus Mercy, and now is over 132 children's hospitals around North America. We're changing the way healthcare is delivered for kids by making it safer for both them and the staff and employees who work with us.
I have nothing to add to that.
Pretty good.
Yeah.
Push a
yeah.
button.
He's my, that's what I say all the time, he's my favorite client, because I just push a button and key messages come out. Yes, what else do you want me to say? Okay, so what are you most proud of with the Train Collaborative?
Well, I think we get caught up in statistics and amount of harm perverted or amount of,
Start over.
prevented.
Prevented. You said
I say averted.
perverted.
I said averted.
You said
Say with a P?
perverted.
Oh, sorry.
That.
Take 2. The Train Collaborative, as with any of our quality improvement and research efforts, can get kind of bogged down in the data. The data are important. They're important to help drive learning, to help for spread. But it's much different to hear about, we went from X% to Y% in terms of our detection, and then we're able to drop that down to a further level in terms of harm prevented. But when Dr. McPherson talks about real-life application of what it's meant when we've developed this protocol, we've worked with our adult colleagues to figure out how to spread the protocols that have come out of Train so that when a child presents in an emergency department in an adult hospital, they're benefiting from the hard work our OCHA members have done to protect kids. And that child example that was shared here at the event with the Attorney General today, that's when it becomes, to me, really impactful, because we don't deal in terms of rates, we don't deal in terms of percentages. While all that's important, we're talking about children. And these are our most vulnerable members of society. And oftentimes, we're their advocates, the men and women who work in our hospitals, who work in our emergency departments, whether they're the pediatricians, the nurses, or others. When those children come in, we have an obligation and responsibility to give them the best possible care in the world. And without the Train Collaborative, we would be continuing to have misses and potentially devastating stories of an example of where a kid might sustain brain injury when otherwise, were it not for the Train Collaborative, that child was actually helped. And when you talk about putting a human face on it, that's really when I get most proud.
One more question. What do you hope is next for the Train Collaborative?
Well, as is always the case, the management at OCHA, we kind of think about where we want things to go, but we rely upon our clinical leaders. And in talking with Dr. Thackeray and the other active participants from our members, it's exciting to think that there is a national and potentially international interest in what we're doing. A lot of what we do is simply trying to think about how to apply things efficiently, rigorously, without much variation. The exciting thing about Train is there's some discovery occurring here by the identification of new protocols that can prevent child harm. But what's really exciting is, while it's worked here, there seems to be a groundswell of interest of how we can then spread this knowledge more greatly across the country. And we've talked quite a bit about the challenges we have when we publicize a finding and we get it into the literature, and the literature then finds its way into the education, the medical education pipeline, and ultimately finds its way into the front lines of practice. Can take 17 years, I think, if I'm remembering some of our leaders talking about that. We've simply compressed that in 2.5, just with this one project. And if we're able to take that and really drive the education in a way that can help kids from around the country, that the sky's the limit. So I'm optimistic that we'll have opportunities to do different kinds of partnerships with other state children's hospital associations. My peers in those states are very interested in what we're talking about, either with the Children's Hospital Association or others, to the Pediatric Academic Society, and of course AAP. I mean, they have a real unique opportunity where we should not take our eye off the ball here in Ohio, where it would be a shame if we didn't have every member of the Ohio chapter of the American Academy of Pediatrics knowledgeable in instituting the Train protocol in their own offices. That'll be a miss. So we want to spread, we want to be very aggressive with that, but we've got to make sure we're taking care of kids that are here in our home state.
I'm Bob Shapiro. Actually use Robert Shapiro, S-H-A-P-I-R-O.
So, Dr. Shapiro.
Yes.
Let's talk about data that you discovered as a part of the Train Collaborative.
Carrie, it's really interesting thinking about the data that we collected, because when we're talking about child abuse, it's a hidden crime. It's a hidden problem. It doesn't come out and show itself when we see kids. And so we're asking ourselves the question, how big a problem are sentinel injuries? How common are sentinel injuries? And when we see them, really what should we be doing about them? And so we did collect quite a bit of data to help answer that question. And some of the data is site-specific, and some of it is data that relates or really describes what's happening around the entire state. So for instance, we found that of those children under 6 months of age who got worked up because the doctors suspected that abuse might occur because of that minor injury that they present with, 73% of those kids had another injury. Now, that's a lot of kids with another injury, but what's really telling is that 23% of those kids had an injury that would not have been noticed from any physical examination or because of hearing the mechanics of what happened. We call those occult injuries, injuries that we don't suspect until we do the radiograph or the other testing. So 23% of these kids had an occult, mostly fracture, which was really important finding to note. Now, something else that we noticed, that it was less likely that providers would order these x-rays if there was a history of some kind of fall or other trauma to explain what might be found. So if a child comes in with a bump on the head and the doctor is told that the child fell off the bed, then the doctor would expect a bump, maybe even expect a fracture, because after all, there was an injury. However, we found that even among those children, 25% of them had an occult injury, and 19%, let me check my numbers, 1 in 5 nearly, had an injury even when the history seemed to fit. 1 in 5 had an unexpected injury, like what Dr. McPherson was talking about, even when they had a history. So this is difficult for physicians. This is difficult for care providers to really incorporate into their care, because after all, they're seeing a young child with an injury, and the provider, the parent, brings them in and says, yep, fell off the bed, I'm just bringing him in because I want to check and make sure there's nothing else wrong. And we don't naturally begin to think, oh my goodness, maybe there are other injuries here. And so that's what the Train Collaborative has taught us, and the data is really demonstrating, hey, even when we don't suspect it, even when we think the injury fits the trauma we're given, 1 in 5, we found an unexpected injury, which helps us to identify those kids who probably are victims of child abuse early before more serious injury happens.
What do you think the best way would be to address the variation among providers?
I think that variation among providers is really an important fact here in Ohio. In fact, among our partner hospitals, the rates in which a workup was done for kids who presented with a sentinel injury varied anywhere from 37% to 60%. So the variation is huge. And even at best, it's too many kids were not being tested. So there's a lot of variation. We found that there was greater compliance with our recommendations. Compliance maybe is the wrong word, but there was greater agreement among providers that abuse should be looked for when a provider was trained either in pediatrics or in pediatric emergency medicine. Family practice, general emergency medicine physicians without those training residencies were less likely to think about child abuse. And so we identified there are certain populations we could direct education towards. We also need to educate providers that, hey, even if you get a history that seems to fit, if you're seeing a 6-month-old or under with even a minor bruise, this is the child who you need to get additional tests on, because it's not at all uncommon that many of them will have an occult injury. We found that Well, no, I already told you, 19% of those kids had an occult injury. I'll tell you something else, Carrie, that's interesting. We often look at psychosocial risk factors, and we say, those families who live in poverty, single parents, parents with mental illness, that we're going to see these kinds of injuries more often. That may be true, but in our screening, we found that it was not helpful in screening out those families who should not have those skeletal surveys and those workups. That families, even without these psychosocial risk factors, we needed to consider abuse in those families too, and that screening families because of a positive or negative psychosocial history was not effective. In fact, it was incorrect.
Is there anything else we didn't address? I'm trying to think of.
See, I thought that maybe we would
Yeah.
get to it, yeah, let's see. I will also tell you if you ask me.
I'm just going to let you go, Dr. Shapiro. This is good.
Carrie, one of the other interesting things that we did, which was the second arm of the TRAIN study, is we looked back on those children who were 18 months of age or younger and who we thought they were victims of physical child abuse. And we looked at the records and we asked the family members if they had had an injury prior to their 6-month birthday. We found 10% of those kids had an injury, but hadn't been recognized or worked up for child abuse. Now, we don't know if we would have identified all those kids as having been abused at that time, but the number is staggering. And the whole TRAIN Collaborative theory of change is that if we identify those kids with injuries early on, if we recognize that they need to be evaluated for possible child abuse, we're going to find some. 10% of those kids who were abused had an injury prior to 6 months of age. So the numbers are really quite important.
That's great.
Okay, well, great. Well, welcome, everybody, to Nationwide Children's Hospital. My name is Nick Lashutka. I have the great honor and privilege of being the President and Chief Executive Officer of the Ohio Children's Hospital Association. Our membership includes some of the world's finest children's hospitals, starting right here with Nationwide Children's, Akron Children's, Rainbow Babies and Children's in Cleveland, ProMedica Toledo Children's, Dayton Children's, and Cincinnati Children's Hospital Medical Center. The power of those institutions is that we agree to work together to solve complex policy problems or issues affecting child health care. And we're excited that you could join us here today for an example of one of those efforts. And I'm pleased that I could recognize Dr. Steve Allen, who is the President and CEO here at Nationwide Children's and a member of our Board of Directors. I'm also thrilled to introduce Melissa Werby-Arnold, who is my counterpart at the Ohio chapter of the American Academy of Pediatrics. OCHA and AAP work very closely with one another on multiple issues. This has been an example, I think, of how when working together again, we can achieve tremendous results to the betterment of kids. Not able to join us today were some of our colleagues from the Ohio Hospital Association. We'll hear a little bit more about that partnership here in a minute, but the work we've done has allowed for us to share transparently how we can improve care for kids, even if that child receives care in a setting outside of one of our members. Together, we're working together to make Ohio the best place for child health. And that's why we're here today. While we have some good news to share about how we're working together to prevent child abuse and how we're exporting this to other places, this is a challenging epidemic, and we're grateful for the leadership that Attorney General DeWine and his team have shared to have confidence in us to take this work to the next level. To talk specifically about what we're doing with regard to our effort, which is called the Timely Recognition of Abusive Injuries, is Dr. Jonathan Thackeray, who's our clinical lead and principal investigator. Dr. Thackeray is a pediatrician at Dayton Children's Hospital. Dr. Thackeray.
Thank you, Nick. I just want to start by offering my sincere appreciation to Attorney General DeWine and your staff for taking the time to be with us today. I'd also like to recognize the representatives of our Ohio Children's Hospital Association, member hospitals, as well as representatives of the Ohio chapter of the American Academy of Pediatrics for being here. So in 2015, we set out with a bold agenda to improve our ability as pediatric providers to recognize and respond to the first signs of child abuse, sentinel injuries. Children who experience abuse rarely experience it as a one-time isolated event. The reality is that they are repeatedly exposed to harm, and sentinel injuries are often the first visible expression of this harm. The problem with sentinel injuries is they're often minor. a single bruise, a small tear to the inside of the mouth. And if we don't identify them, or if we don't respond appropriately to them when they are identified, children are at risk for additional harm. We started by learning where we, as a group of children's hospitals, needed to improve, and we found quickly that there existed significant variation from hospital to hospital in our ability to even identify these infants. One hospital, for example, was identifying about 50 infants a year with sentinel injuries, while another comparable hospital was identifying 5 times as many. We found that our adherence to the evidence-based series of recommendations was low. There's a tool we have, a series of x-rays called a skeletal survey, and it's one of the standard diagnostic tests that we do when we see an infant with injury. We found that we were doing these less than 40% of the time. And we wanted to better understand why. So we reached out to several hundred providers across the state of Ohio and surveyed them. Our results have just been accepted for publication. And what we found was interesting. It turns out that only 1 in 3 providers could distinguish an accident from an abuse case based on the clinical scenario. The survey identified opportunities for education for pediatricians, nurse practitioners, social workers, and nurses. We also found hidden bias in our decision-making for which children received further evaluation and which did not. Based on our findings, we agreed that a bundle of care was in order, a checklist of items that needs to be completed for every infant who comes through the doors of our hospital with an injury. Not to replace the judgment of the clinician, but to ameliorate educational gaps and potential bias. We feel strongly that every infant needs a head-to-toe examination, and for those infants with an injury, there's a prescribed list of tasks that needs to be completed. Infants with injury need x-rays, they need someone to better understand the psychosocial factors that occur within their home, and the provider should pick up the phone and contact an expert in child abuse to better assist the family and often to help protect the child. We took that bundle to over a dozen community hospital partners with our Ohio Hospital Association across the state and worked to identify opportunities for improvement with these partners. Today, I want to highlight 2 key impacts of our collaborative work to date. First, I want to share with you that we are doing better at identifying sentinel injuries. If you're not familiar with quality improvement work, you pick a problem of interest, in this case sentinel injuries, and as you start to focus attention on it, as you start to measure it, you ideally hope to see the frequency of that problem increase. And that holds true here as well. It's not that we think abuse is becoming more common in our state, absolutely not, but our hypothesis was that injuries were happening and we just weren't noticing them. And if you look at the chart on the right, you will see that we think we're correct. We've increased our identification of sentinel injuries from 60 per month in our baseline year to currently 90 per month. That's an increase of 50% across the state. Second, the overall aim of this project is to reduce the number of children who come back with a second injury. And this is what the chart on the left visualizes for you. Before we started this work, we recognized that 1.5% of children with a sentinel injury came back within a year with a second injury. Today, we can tell you that we've quadrupled that identification rate. We're now recognizing that over 6% of infants with sentinel injury are returning with a second injury. We anticipate that soon, as we implement interventions across the nearly 20 or so hospital partners, that we can reduce the number of children who experience re-injury. And that brings us to today. Today we embark on phase 3 of this quality improvement work, and we're excited to announce that we are partnering with 9 primary care practices across the state. These practices, with the coordination of the Ohio chapter of the American Academy of Pediatrics, will learn about sentinel injuries and join into a standard QI framework within which they can both learn from and teach each other about their experiences seeing these children each and every day. We begin tomorrow with our first learning session right here in Columbus, and we could not be more excited to welcome them into our collaborative, and we're confident that their commitment and their efforts will have significant impact in improving outcomes for these children. Let me again thank Attorney General Mike DeWine and his staff for making this work possible. Attorney General DeWine has a long-standing dedication to children, including those experiencing abuse, those who are victims of human trafficking, and those who are placed into foster and kinship care. His commitment to this work is commendable. So I've shared with you a little bit of early data from our work, and data's great, but it's an entirely different thing to hear about real families and real children who are impacted by this work. So it's my sincere pleasure to introduce our next speaker, who's here today to share such a story, Dr. Paul McPherson from Akron Children's Hospital.
Thank you, Dr. Thackeray, and thank you, Attorney General DeWine, for the foresight and the vision and leadership that this is provided for our state and for the children here in Ohio. I have the privilege of working as a child abuse pediatrician in Akron Children's Hospital, and we partnered with one of our community hospitals during phase 2 of this program. And I'd like to share a story with you all. A mom brings in a 3-month-old infant to the hospital. She saw that his arm wasn't working right, wasn't moving. Mom had put the baby down to bed, and in the bed was a 2 and a 4-year-old siblings, cousins. And after a while, Mom went back to check on the baby, to feed the baby, and realized that the arm wasn't working right. So she brings the child to the Altman Hospital, and they hear the story, and they get an x-ray of the arm. And when they looked at the results of that x-ray, they saw a fracture in this child's upper arm. And it was a pretty bad fracture. So they asked Mom about it, understanding that a 4-year-old and a 2-year-old wouldn't roll over on a child in bed with the force necessary to break the arm. And then Mom suddenly starts to tear up. She starts to sob. And then she tells the physicians, it was me in the bed. I'm the one that probably rolled over accidentally while I was sleeping and broke the arm. And the story could have ended there. But because of the work of the TRAIN Collaborative, because of the work of Altman Hospital and their participation in this quality improvement project, they went forward in their evaluation. They got these x-rays that we've been talking about, that Dr. Thackeray mentioned. And upon getting these other x-rays and studies, they identified a significant skull fracture in this child. And they identified over 12 rib fractures on the left and on the right side. And suddenly the whole dynamic changed. This wasn't a 2 or 4-year-old child. This wasn't a mom who accidentally rolled over on the baby. This was something much worse. Now, despite the fractures that this child sustained, despite the abuse, this was a positive outcome. Because what we didn't find in that child was brain bleeding. What we didn't find in that child was brain swelling. What we didn't find in that child were eye injuries that could have caused visual impairment. What we didn't find in this child was a child coming in dead on arrival. Because frequently, as abuse escalates in the home, the injuries become much worse. And as part of the TRAIN Collaborative, it's important that we find these seemingly minor injuries and take a closer look, because these infants can't talk to us. But we can do a little bit more investigation and evaluation. And so I'm grateful for this project that has helped this child and so many others. I'm happy to report that this infant's fracture is healed, and the infant is doing much better now. Thank you very much, and I'll turn the podium over to Attorney General DeWine.
Thanks, Doctor, very much. My first job out of law school was as an assistant county prosecuting attorney in my home county of Greene County. And I think the thing that shocked me the most about what I saw was how adults could treat and did treat children. Cases of sexual child abuse, physical child abuse, mental child abuse, psychological. I was shocked by that. And I will tell you that still today I am shocked by that and what I have seen. It really is a moral imperative that we protect kids. Governments do a lot of different things, but there's nothing that I can think of that could be more important than protecting the most vulnerable members of our society, and that is our children. Something else that I learned at that time in the prosecuting attorney's office was that in so many of these cases of child abuse, when you went back and tried to recreate the history, what you found is that there were indicators of child abuse that were not noticed, that were not paid attention to, some cases not even reported at all. This study that you're hearing about today came about because of money that we had in the Attorney General's office. We went to the we went to the children's hospitals around the state, went to the association, and said, we want to take this money that was a settlement and to use it for children. And there were proposals that were set forth, and this is the proposal that was really picked. As an example of children's hospitals working together. I've had a long association with children's hospitals going back many, many years. First with our own children, now with our grandchildren. But I've also had a professional relationship, particularly when I was in the United States Congress. We are blessed in Ohio. We are blessed with an amazing number of unbelievably great children's hospitals. I do not know any other state in the union that is as blessed as we are. It has been my dream for many years to see a much, much closer working relationship between these children's hospitals. I think this can be of great benefit, first of all, to the children, but second of all, of course, to the parents and family members, but also to the state of Ohio, all of us collectively. We are blessed with these children's hospitals. And frankly, the more that they can work together, the more they can share data, the more they can work on best practices, the better it's going to be for our kids. So I congratulate them for doing this. I congratulate them for pulling together. I look forward to working with them in the years ahead as they cooperate together to improve the quality of life of our children. Thank you very much.
Attorney General DeWine, thank you for those kind words, and you have our commitment to continue that very important mission you just mentioned. And I know I speak on behalf of all of our members, because most importantly, as some of you know, I'm a parent, and my wife makes sure that I wake up every day coming to the office to think about how we can do precisely what you're challenging us to do. And I'm reminded by a quote that I heard you say many times. I kind of think of it as the January 9, 2011 quote, but the job of the Attorney General is to protect children and their families and protect the most vulnerable among us. And that's precisely what this work is all about. And we're grateful for your confidence in us and our pediatricians and the partnership with both AAP and the Ohio Hospital Association. This will conclude the formal press conference. All of us, I know, would be happy to take questions from the press should you have them. Thank you.
Once you identify a sentinel injury, how do you intervene? What do you do?
Well, so the intervention's different depending on every case, right? The intervention when a sentinel injury is identified is different for every case, right? Some cases rise to the level of being reportable abuse to Children's Services where their assistance needed. Some injuries don't rise to that level. Some injuries give us a chance to interact with families and identify other issues that are going on in the home, whether it's substance abuse or mental health issues or any of the social drivers of health, poverty, food insecurity, poor transportation. Just it gives us a chance to interact with that family in a variety of different ways.
Okay, the statistics you cite, is that just from the Children's Association member?
Yeah, the data you're seeing here is from the 6 members of the Ohio Children's Hospital Association.
Talk about phase 3, kind of focusing on 9 primary care practices.
Mm-hmm.
What's the hope as far as expanding from there?
Well, so We're still inviting practices to join, so there might be a few more primary care practices that join us before it's all said and done. But really, what we've found is there's opportunities for education everywhere. So when we think about next steps to train, we recognize that the medical system is just one piece of the puzzle for these children, right? They interact with the child welfare system, they interact with a variety of different community agencies. And just as we as pediatric providers identified early on that we had educational gaps, we're seeing the same educational gaps in our community partners who work with these children as well. So I think there's tremendous opportunity for us to work with them and share knowledge about sentinel injuries, why they're important, why they indicate a child's at risk.
Is there hope that it kind of becomes a thing where there's best practices for all kinds of groups that are safe in this program?
Absolutely. We would love for all these different agencies that interact with these children to share the common language of what we've been developing in the collaborative. We talked about this bundle of care. We would love to have medical professionals, when they're talking to child welfare professionals, talking about this bundle of care and understanding what the other is saying and approaching these children in a coordinated and consistent way.
How many deaths are there annually from child abuse?
Well, so that's a really good question. So across the country, it's estimated there's about 1,500 deaths from child abuse each year. That's a gross underestimate, we think, of the number of children who die from abuse. As part of this collaborative, it's been really difficult to track and measure child deaths, and part of that reason is because children, when they die, they don't always die within our children's hospitals. And so when it happens outside the walls of a children's hospital, we don't have that data available to us.
Is this something that could or should be incorporated in our medical schools?
Yeah, absolutely. So we've actually spent a fair amount of time going to some medical schools around the state, going to children's hospitals around the country to present, not just on the TRAIN collaborative, but on sentinel injuries in general. But yeah, there's plenty of opportunity and room to improve the amount of child abuse education that pediatricians in training receive.